Good luck.
Good morning, Providence. Good morning, nursing community. Good morning, scientists in nursing. I'm Deb Burton. I am the Chief Nursing Officer for Providence St. Joseph Health, and I am absolutely thrilled to have the opportunity to welcome you to this incredible opportunity as part of our nursing seminar series. Before we get started, I want to remind you that today is a very extra special day, partly because last week we learned that because of COVID, the World Health Organization Year of the Nurse and Midwife has been extended. So we get to have a whole nother year to celebrate the amazing legacy of Florence Nightingale and nursing around the world. I also want to wish Joyce Dombrowski, who's the chief executive for the Montana market, but also longtime chief nursing officer at St. Patrick in Missoula, a very happy birthday. I want to start very briefly by telling you about the many gifts that COVID gave to us. These were not gifts we asked for, nor we necessarily thought we needed, but they are gifts. One is we got to launch this incredible nursing seminar series, an opportunity to bring our nursing community together with technology in ways that we probably would not have done in our past lives. Secondly, I mentioned that we get another year to work on the Year of the Nurse. This has been an incredible opportunity to tell the story of nursing across Providence, and especially the story of evidence and science within nursing. I do want to say forever that COVID gave us the opportunity to lean heavily on science and evidence in real time. Many of you lived through us asking the nurse researchers to give us an assessment of a piece of PPE, protocol, you know it, and nursing science stepped up. But the coolest part of this, I think, was reflected this morning when we were getting ready for this seminar series, and some of our colleagues who are actually involved in patient care actually thought they needed to ask permission to do their presentation wearing a mask. What that means is we have engaged the caregiving community in a way I'd always hoped we could, and we have people who are actually engaged in caring for patients right now that will also be presenting. Last, however, what I want to say I'm most proud of and excited about and humbled by is the depth and breadth of what was submitted for the series. Holy cow, it was every aspect of our organization, every level of practitioner, and every part of our organization geographically, and the numbers were staggering. More importantly, the quality and the relevance of the submissions was amazing. So with that, I'm going to stop talking and get on with the really important work of today. Congratulations and thank you.
Thank you, Deb. And next slide, please. I second welcome you all to this event today. We've all been so excited to share what we're about to share with you. First, a few reminders. This is part of a nursing seminar series, and we have 3 more scheduled this year. You can see that where we are today, nursing research, and 3 more coming up soon. You can find out more about this at the link there at the bottom, which may also be in your chat. Next slide, please. Just a few logistics. Everyone in the live environment is muted, so you won't be able to unmute yourself or speak. There is a live chat feature. I hope you see that with your Q&A icon. And these meetings are recorded. Because of our tight timeline and our we've really got this talk today packed, we won't be able to take live questions from you. But please type them in, and our researchers, our investigators, or our staff will be able to get back to you with what is needed. Next slide, please. This event, of course, offers C&E. We have no conflicts to disclose. We have 3 objectives. You can read them here, but to describe nursing research, to explore the value of the spirit of inquiry, and discuss implications of at least one of the presented studies. There will be 4 studies presented. To receive credit, you need to attend the entire course and do the course evaluation. So there will be instructions for that as well in the chat box. Next slide, please. Just a little bit about our agenda today. We'll start with reflection and safety story. I'll come back and talk a little bit more about research and clinical scholarship, and then we have the fun part of the day, which is to really celebrate what our nurse scientists and investigators have learned with 4 different presentations, and then finally a wrap up. Thank you. Next slide. So first, I'd hand off to my friend and colleague, Dr. Mary Waldo, the Regional Director of Professional Practice Quality and Research in the Oregon region. Mary.
And Mary, I think you might be on mute.
Thank you. So thank you, Beth. This is one of my favorite reflections. It is not attributed to a single person, but to the Arizona Hopi Nation, and it's titled Elder Wisdom. You have been telling the people that this is the 11th hour. Now you must go back and tell the people this is the hour. And there are things to be considered. Where are you living? What are you doing? What are your relationships? Where is your water? Know your garden. It is time to speak your truth. Create your community, be good to each other, and do not look outside yourself for the leader. This could be a good time. There is a river flowing now very fast. It is so great and swift that there are those who will be afraid. They will try to hold on to the shore. They will feel that they are being torn apart and will suffer greatly. No, the river has its destination. The elders say we must let go of the shore, push off into the middle of the river, keep our eyes open and our heads above the water. And I say, see who is here with you and celebrate. At this time in history, we are to take nothing personally, least of all ourselves. For the moment we do, our spiritual growth and journey comes to a halt. The time of the lone wolf is over. Gather yourselves. Banish the word struggle from your attitude and your vocabulary. All that we do now must be done in a sacred manner and in celebration, for we are the ones we have been waiting for.
Thank you so much, Mary. That was beautiful. Next slide, please. And next we will have a safety story from another dear colleague and nurse scientist, Dr. Sherry Mendelson, who's the Magnet Program Director at Holy Cross and also research scientist for the Southern California region. Sherry.
Thank you, Beth. Go back to the slide, please, for just a second. Thank you. So I want to talk, instead of a very specific safety story, I want to talk about general safety and Mythbusters flowing with the evidence. Next slide, please. Thank you. So what is the process for change and why is change important? We have old practices and sometimes we have to ask the question, why change? Isn't what we're doing adequate? And then the second question we have to ask when we're looking at old practices, what is the risk of not changing? And when we're looking at potential new practices, the questions we have to ask, or the question is, what are you done when you make a change? And the answer is never. And I can't say that strongly enough. Next slide, please. So the one I want to focus on as a general safety issue is oral care. Prior to 2010, oral care, if done, consisted of toothbrush and toothpaste or simply a mouthwash rinse. And when I started into practice, oral care was not a concern for hospitalized patients. And I think back to those days and I'm like, wow. Rates of ventilator-associated pneumonia, or VAP, were higher than desired and generally studied in patients with endotracheal tube ventilation support in the early 2000s. Beginning around 2013, research demonstrating use of chlorhexidine in addition to toothbrushing with toothpaste sparked wide implementation of this practice change. Current studies have included determining if VAP rates can be lowered through use of a validated chlorhexidine bundle for ventilated patients with a tracheostomy. So it's gone the next step. This translational research to a different subset of the ventilated population demonstrated effectiveness. Can we go to the next slide, please? And that was then. Today is today. And some current considerations with oral care ask whether chlorhexidine-resistant bugs are a concern. So we haven't rested on our laurels of changing practice. And for critically ill patients receiving mechanical ventilation, low to very low certainty evidence, which should tell you that we don't know all the answers yet, suggests no obvious differences between toothbrushing and no toothbrushing in the incidence of VAP and mortality, duration of ventilation, duration of ICU stay, or adverse effects. So it may be that chlorhexidine alone may be the answer, not toothbrushing with toothpaste, but there's very low evidence at this point to support that. Can you go to the next slide, please? And I have oral care references. For a safety story, do you really need references in here? The reason I put it in here is to encourage you always to look at your questions and to look at Mythbusters and where we need to move forward, looking at good references. And we have an excellent library services possibility within Providence to do this. And the second one I put in here is from the Cochrane database, which we have access to through our library services. And I never finalize any recommendations without at least looking at the Cochrane database, because those are systematic reviews of all current research and seminal works that help us to understand what best practices are. And that's what we keep our patients safe with, is using best practices and busting myths of old practices that are no longer supported by current research. Thank you.
Thank you, Sherry. And I would leave it to a nurse scientist to bring science straight to the safety story. Nice job. I've had the honor and privilege of being one of the co-leaders of the Research and Clinical Scholarship Council since 2013. Though my title underneath my name here does not align with that. And that's because I recently, in April, took a new position with Providence of Executive Director of Environmental Stewardship. Now, I would love to talk to you about the science behind environmental stewardship, but we won't do that today. Instead, I consider today a celebration of the work that many of us have been doing for now 7 years, and we can see the results in what we're sharing with you today. So I'll just give a little bit more background. Next slide, please. So a rhetorical question for you all to just think about while we sit here together. Why is a spirit of inquiry important? Sherry just gave you an example of how by understanding the literature, understanding what science is telling us, we can achieve better safety outcomes. Why else is it important? How do we do it? Why have we invested at Deb Burton's leadership when she started us down this road back in 2013? Why have we invested in really educating nurses across Providence to be able to use the scientific method, to use literature, to understand research and EBP project design, to know something about analysis, and very importantly about the implications for nursing and how we will interpret that. So I can tell you that there's lots of reasons, and I suspect that all of you who are practicing nurses know them. Anything that aligns with the quadruple aim, from nursing satisfaction to better quality outcomes to patient satisfaction to cost containment. I would add professional development, enthusiasm, some joy, some meaning in our work, and the satisfaction of knowing that we're contributing to the body of knowledge which really guides nursing practice, especially nursing practice in Providence. So there's been a small group, always there's a small group that's interested in this work, and what we've been really committed to is expanding that group. We're helped by the requirements of Magnet and Pathways to Excellence that turns all of us toward thinking about, well, how are we going to measure our outcomes? When you start to think about how we measure, that takes you right to the scientific method and some of the analytic skills that we use. So I leave that as a question for you. My second question here is, have you heard of the Providence Clinical Scholarship Framework? I don't know, if we had a survey function, I could tell right now how many of you find this image on the right, if you recognize it. This is something that we developed early in our work together for the council, and I'd say this still holds true. And I'm just going to talk you through it in case you haven't seen it. You can see that this is a tree or a flower or perhaps a brain with lobes, and the core of it is this Clinical Scholarship Framework for Nursing. There are 3 lobes or petals: to inquire, to improve, and to inform. Inquire is to ask the question in the first place. What is it that I'm driven to understand better? What is it that I want to make a difference about? And then we do the improvement work, which could be a research study, it could be implementing a practice, it could be a quality improvement or an innovation. And we study it. That's the study itself. And then always we need to inform, because science is not done until it's disseminated. That is a necessary feature. It's actually considered an ethical feature of a research study. If you're involving participants, you need to share what you've learned. Across the top, it says continuous evaluation of outcomes, evidence, and practice. It's because we don't do this one day and then we're done. We do this all the time, continually, and we continue to talk about it. Across the bottom, as the bedrock that holds up this tree or flower, is building knowledge, capacity, and commitment. So Deb really started out with this commitment, and we have taken it to expand knowledge wherever we can and to build capacity. So I'll tell you a little bit more about that in the next slide, please. On the right, I'll start on the right there with that arrow. This gives you a little bit of an idea of a 10-year plan that we've used for nursing research and clinical scholarship. The early years, we were just getting started. And then the next few years, we spent really spreading knowledge, trying to get people up to date on what the IRB does, what's the difference between EBP and research, what are some analytic skills that we need to use, how do we interpret what we found. And now in 2020, we've really started how we see this as the next 5 years of making sure that scholarship, the clinical inquiry itself, is foundational to our practice, so that our practice is driven by our evidence, but our evidence is also driven by our practice, because we live in this lab, this laboratory of the immensity of Providence, with all of the opportunity we have to study nursing practice. It's incredible opportunity. And we hope that this is leading us to this final point on here, which is not a final point, it's just the 10-year point of being leaders in clinical scholarship. We are the 3rd largest health nonprofit health system in the nation. We are committed to nursing. We are committed to be best in the West. And this is a part of that. And we would like for us to be known for that, and that to be part of our own nurses' identity. So on the left, we have, I mentioned when the council started, but we also have regional research leads. So in each region, you all can find out, and you can find out where it says learn more here, you can click there and find out who is your regional research lead if you need to contact someone. I mentioned the 10-year plan. We also do annual charters with goals each year, and we achieve most of them. We often have an annual report. That was a little bit waylaid this year with COVID. We collaborate closely with all sorts of groups, but I did want to call out the University of Providence. We really aligned a lot of what we were teaching early on through Dr. Savage's work, key member of our team. Library services, as Sherry mentioned, we could not do this work without the fabulous library we have. We have one of the best medical libraries, I'm sure, especially for a non-academic center. It's just phenomenal, and the librarians are very involved with us, and we lean on them a lot. IRB, our Institutional Review Board, also has been a key partner. We have worked together to align our needs and their needs to make sure that we are not violating any regulations and that we're providing ethical research. Next slide, please. So what is it that we do? Well, we do a lot of studies and projects. So how many studies and projects? Well, this varies year to year, but hundreds. We do hundreds of studies and projects per year because these are happening all over the health system. We have dozens, if not probably 50-ish publications a year in peer-reviewed, mostly nursing journals, but sometimes other journals. We also have many, many posters that are out in the world to other countries across our nation, in our region, and of course within Providence. Some of our ministries have EBP courses. About, I think, 8 or 10 different ministries have these courses now. And really, we are all about changing practice and ultimately changing nursing. I mentioned about dissemination, and this is very important because it's part of really being true to our involvement of participants, who have enrolled in our studies, but also it's the way we advance nursing practice and knowledge, and it's the way we advance providence too. So we work on that a lot, and we track that, and we want to amplify that. Today is an example of internal dissemination, and so we will go further by putting our posters on Digital Commons, which we will have the link for you also soon in an upcoming slide. So those are sort of some of the things that we do, and it's really fun. Next slide, please. And we need a drum roll. We need a drum roll. Because now here we are to the poster awards. Next slide. I want to tell you just a little bit about how this has happened. So this was going to happen at our nursing summit. We had put out a call for many nursing posters. Because of COVID, that got changed from a live event to an online event. And we decided to take a special time today to really amplify the work that the nurse scientists have done. So we ended up with more than 60 posters. We divided them into 3 categories. That was research, evidence-based practice, and QI, and inspirational. 7 different nurse scientists reviewed these posters with an algorithm, a numerical algorithm. And out of that, were chosen 3 winners of the categories and 3 honorable mentions for the categories. 4 of these posters will be presented today, and these are all available in Digital Commons. This is the link, and you can also get there off of the PNI, the Providence Nursing Institute site. Okay, with no further ado, we will start with our first category, which is research and innovation. And the honorable mention goes to, next slide, Kristen Lowry, Dr. Martha Highfield, and Dr. Sherry Mendelson from Holy Cross in Mission Hills, postpartum quiet time effects on breastfeeding, satisfaction, and interruptions to couplets. You can read about this poster on Digital Commons. Next slide, please. Congratulations, you all. And the winner is, next slide, Dr. Tricia Saul, who is going to take the mic now and tell us about her study that she has recently completed. It's really exciting. Thank you.
Thank you for that introduction, Beth. Hi, I'm Dr. Tricia Saul. I will be talking to you today about my dissemination work. Next slide. And the title is Complementary and Alternative Medicine Attitudes and Use in Caregivers of Patients with Cancer. I just really want to thank my dissertation committee for their support. When I am discussing this, there's a few things I want to clarify. When I say CAM, I'm specifically talking about complementary and alternative medicine. And then when I talk about caregivers, I'm talking about informal caregivers, that of the patient, maybe a family member or a close friend. To start, I want to discuss the background, why lung cancer. So cancer in and of itself is the second leading cause of death in the US. Lung cancer is the second most common cancer, however, it is the leading cause of cancer deaths at 27% of all cancer deaths. Additionally, the 5-year survival rate, meaning day of diagnosis to 5 years out, is only 18.6% in the lung cancer population, which is significant when you compare it to colon at 64, breast cancer at 90, and prostate cancer at 99% 5-year survival rates. And these individuals require a certain amount of support, which is also often provided by an informal caregiver. And what I had felt as a bedside nurse, as well as what the literature tells us, is that the more support that these individuals require, the lower health-related quality of life the caregiver has. Additionally, a meta-analysis showed that 26% of these caregivers reported depression, and almost 40 reported some type of anxiety in their caregiving role. And so that brings me to CAM, complementary and alternative medicine. There is some literature that supports that some of these modalities can improve psychological well-being, although it's really not studied very well in the lung cancer caregiver population. And so really the purpose of this study was to see if caregivers of lung cancer are interested in CAM modalities. Are they using specific CAM modalities? And what is their overall attitude toward? And so that's kind of my jumping off point. We need baseline information before we can do an intervention study. And so I did receive IRB approval from the University of California. Additionally, I received written permission from multiple sites in the Southern California region for Providence, and also from UC San Diego. The methodology that I used was a cross-sectional survey. It was 128 questions, 5 different validated surveys were used, about 25 minutes. And then after the participant completed the survey, they received a $25 gift card as a thank you for their time. The inclusion criteria was specific. It included adults who self-identified themselves as the primary caregiver of cancer patients and who spoke and understood English. And now we're going to get to the results, which I think I tried to save the most time for. I had 62 participants in this study. What was surprising was the mean age. So in general, cancer caregivers are over the age of 60. In this particular study, which it may be niche, is a 37.9. Just over 50% were female. We had a nice diverse population. Just over 50% were white. However, about 15% were African American and 15% Hispanic. Over 70% were college educated, full-time employed, and had an income of greater than $76,000. In terms of characteristics as they related to the patient with lung cancer, 40% were the spouse, 85% lived with the patient, greater than 90% had been caring for this for over 6 months. And then about 72% provided at least 4 hours of caregiving a day, which is pretty important considering a lot of them had worked full time. So next slide, please. So what we're looking at on the screen is all the CAM modalities that they were asked to review. And so we had these different CAM modalities with a short description and the option of, I've used this CAM modality in the last 6 months, which is the gray. I've used this CAM modality greater than 6 months ago, which you see in the yellow. And then what you're not seeing on the screen were the other 2 options, which I've never used and would not use, or I've never used, but I would be interested in using or consider using. And so a lot of surprising things came out of this survey, exciting too, I should say, but 93% of the participants have used at least one CAM in the last 6 months, one different CAM modality. What's even more surprising is that on average, these individuals were using 4.8 or almost 5 different CAM modalities in the past 6 months. So that was really good to hear, considering my hope is to do an intervention study after this. Additionally, in terms of attitudes toward CAM, it was surprisingly positive. It was awesome that 85% of this population had a positive attitude toward CAM. So next slide, please. So what we're looking at here is a correlation coefficient. So just to give you an idea, 0 means no correlation, 1 is a strong correlation, and pay particular attention to rows 5 and 6. So education, full-time employment, and income did have a positive correlation to both CAM attitudes and CAM use. And living with the patient did also have a positive correlation. Now, in CAM attitudes, you're going to see that negative, which would normally make you think, oh, there's a negative association. However, CAM attitudes was reverse coded, meaning the lower the score, the more positive attitudes you had. Also, there was a correlation between CAM attitudes and CAM use, positive correlation. Next slide, please. This next slide is the regression models that we did, and full-time employment, living with a patient, and age explained 34% variance in CAM attitudes, where relationship to patient income explained 32% of the variance in CAM use. And I really could go on for days with this particular one, but time does not allow it. So we'll go to the next slide. And I just want to wrap up. This is a a cross-sectional survey. So there is a number of limitations. I do want to highlight our goal was not causation. So please do not take away that there's any cause and effect going on here. We were looking at correlation. So really we can do a pilot study with a specific CAM intervention and looking at outcomes of psychological well-being for this particular population. Additionally, it is a convenient sample, and a lot of the recruitment ended up, because of the times we're in, ended up being predominantly online, heavily in lung cancer Facebook caregiver groups that I'm part of, as well as word of mouth in the Southern California and LA area. And so with that being said, there's going to be a limitation for those who maybe aren't as online savvy or aren't in some of these caregiver groups. Also, this was just for the this was only the English speaking population. And so we're missing out on in a whole different group. And so finally, what does this mean for the future? Well, our hopes is, just like I have said, is to do a study. And I think we've got some foundational knowledge, and I'm very excited about the results. So thank you very much.
Thank you, Dr. Saul. Fabulous study, and I agree with you. It'd be great if we could talk about that more. I hope to at some point with you. But now we'll move to our next category, which is evidence-based practice and quality improvement. And our honorable mention goes to a number of people from St. Joseph Hospital of Orange, and the lead author is Cindy Morton. So congratulations to all of you about implementing a neonatal hypoglycemia protocol with glucose gel. Great work. And our winner today goes to, next slide, please, aromatherapy for first-line treatment of post-operative nausea and vomiting. And we have with us Michelle Leiby, designated charge nurse in the PACU at St. Patrick Hospital, and she'll be giving the talk for her and Katie Trocchi today. Michelle.
Thank you, Beth. My name is Michelle Leiby, and I have worked in the PACU at St. Patrick Hospital for the last 20 years. St. Patrick Hospital is a 200-bed hospital in Missoula, Montana. Our OR has 11 OR suites, and our PACU has 13 bays. Next slide, please. Just like to give a little background. Like Beth said, the title, aromatherapy for first-line treatment of post-operative nausea and vomiting, PNOV, in the post-anesthesia care unit, or PACU. I had the opportunity to attend the 2018 ANCC National Magnet Conference and listen to a talk on aromatherapy. After learning about the ease and potential benefits of this non-pharmacological treatment, I was excited to bring this idea back to St. Patrick Hospital. After reviewing the American Society of Peri-Anesthesia Nurses guidelines, conducting a literature review, and making an evidentiary table, we concluded that there was a lot of supporting evidence that aromatherapy was a very valid treatment for PONV. So the purpose of this study was to find out if using non-pharmacological treatments would decrease our use of IV antiemetics. So we submitted our project to the St. Patrick Hospital IRB and were approved for an EBP project. The Soothing Sense company that distributes Quizzies donated 100 of their quick tabs to us so that we were able to do our project. If you look at the methods, once a patient complained of nausea, we asked them to rate their nausea on a 0 to 4 scale. We would pull the quick tab, place it underneath their nose, and have them take some nice big deep breaths. After 5 minutes, we would have them reassess their nausea and give us another another rating. If the patient's nausea was not improved to their satisfaction, we would ask them if they would like an antiemetic at that time. Next slide, please. The results were very exciting. We reviewed the use of the IV antiemetics in PACU before we even began our study. We looked at data over a 6-month period. 139 patients complained of nausea, and of those, 39 patients were medicated with IV antiemetics. So 100% of the patients received IV antiemetics, which was our standard. After the study was completed, we had 64 data sheets. With a population of 64 patients scored, 28.13%, or 18 out of 64 patients required additional antiemetics. 71.9%, or 46 out of 64 patients did not require any more IV antiemetics. Next slide, please. We also asked our patients if they felt like Quizizz was beneficial. Even in patients who had the aromatherapy and it was not completely effective, 90.48% of patients still found aromatherapy to be beneficial, while only 9.52% did not. Next slide, please. We also asked if the patients were satisfied with their treatment of nausea. 92.3%, or 60 out of 64 patients, reported satisfaction in their treatment of nausea, and 7.7% reported their nausea to be treated to their satisfaction. What's very exciting about the aromatherapy is that it's good for 3 days. So not only could they use the product here in the recovery room, but they could take it to their next phase of care or even take that home with them. Back to the poster, please. To conclude the presentation, let's look at the discussion. There were a few limitations in the completion of this project. The intention of the study was to have a population of 100 patients. However, only 64 patients were included due to errors in the collection of the data and missing products. Other departments in our facility caught wind of this great product and utilized some of our product that we were using for our study. The staff also reported that the nausea scale was a bit confusing. Overall, we found the use of aromatherapy as first-line treatment for nausea and vomiting in the PACU greatly impacted the use of IV antiemetics. The use of antiemetics on complaint of nausea dropped from 100%, which was our standard, to 28.1%. with the implementation of the aromatherapy. This positive result led to the hospital-wide protocols being made, product purchase, and now is stocked in all inpatient care areas, and just the change of practice in our PACU. Thank you.
Thank you, Michelle. That's a wonderful study and nicely told, very clear. Next, we're moving to our third and final category, but we have two posters to present in this category. So this is most inspiring, and you're going to hear from both the honorable mention and the winner of this category. So the honorable mention first is Marissa Gillespie-Aziz, Zoe Anastas, and Mary Waldo from the Oregon region, and I'll let them tell you in more detail about their study. Thank you.
Good morning, and thank you, Beth. My name is Marissa Gillespie-Aziz, and along with my colleagues Zoe Anastas and Dr. Mary Waldo, I am pleased to present our poster, Enhancing Nurse-Led Rapid Response Teams to Save Lives, on behalf of the Oregon region. Next slide, please. We would like to acknowledge the contributions of the many nursing and multidisciplinary colleagues throughout Oregon who have provided support for this work. The purpose of this program is to improve patient outcomes through standardized and reliable rescue following rapid response activation. Next slide, please. Currently, there are no regional measures specifically tied to rapid response, but data from related areas suggest we are not 100% reliable in our recognition and management of deteriorating patients. For example, there was an increase in the number of sentinel events related to vital sign instability throughout the region in the quarters preceding this work. Additionally, documentation of repeat vital signs and provider notification in response to news alerts was below target. While not shown here, there was also a wide range in performance between the Oregon ministries. We recognize that rapid response nurse is not solely responsible for documenting these elements, but rather the rapid response nurse partners with the direct care nurse. The rapid response nurse plays an important role in educating and mentoring the bedside caregiver in their roles and responsibilities during these events. The impact of these findings is broad because ministry rapid response teams serve as the clinical safety net for all patients, as well as visitors and caregivers. Their expertise is shared with bedside nurses through consultative and interventional support. We look to our rapid response nurses to be a pivotal bridge to treatment for acutely unstable patients and as a resource for our less experienced caregivers. In light of the fact that each Oregon ministry utilized its own rapid response policy and offered limited training for nurses in the role, our data and the literature validated that variability in rapid response practice could be contributing to variability in patient outcomes. Next slide, please. To address variability in practice, we developed a regional evidence-based clinical practice guideline and a credentialing program for rapid response nurses. The guideline includes standardized rules and responsibilities for RRT and direct care nurses, a clinical escalation protocol to support getting the right resources to the bedside at the right time, and targets for patient outcomes as a result of RRT intervention. Not every aspect of rapid response could be standardized regionally, so the guideline also includes ministry-specific addendums outlining content unique to each location. The credentialing program includes online training through HealthStream, high-fidelity simulation, and a pre-post learning assessment of self-perceived knowledge. Initial training is being completed with all Oregon rapid response nurses and will be offered twice annually going forward for those new to the role. Next slide, please. Our current sample size includes 73 Oregon rapid response nurses. We are continuing to collect data as we resume training that was paused due to the COVID-19 response. We're anticipating an additional 45 participants by the end of the year. Our data thus far suggests that training has increased perceived knowledge of the RRT clinical practice guidelines, and nurses with less experience in the rapid response role report greater benefit from the training program than those with more experience. For example, RRT nurses with less than 4 years of experience reported improved preparation for coach mentoring in their role. Rapid response nurses with less than 9 years of experience reported that the training will improve outcomes and role effectiveness. Additional preliminary feedback that we have gathered from participants since the COVID-19 response has validated the value of standardization and simulation for rapid response nurses. Next slide, please. Overall, development of an evidence-based regional rapid response guideline is the first step to standardizing practice. Implementation of the standard will be dependent on each individual ministry. Additional follow-up is needed to evaluate the impact of the RRT practice guideline and nurse training on patient outcomes. Thank you very much.
Nice job, Marissa and Zoe and Dr. Waldo. Such an important topic, and we can start to see the difference between these studies, and they're all part of nursing practice, so really wonderful. Next slide, please. And so now we go to the winner of this category of most inspiring, and this is yet another topic that some of you probably haven't thought about. And this is going to be presented by Sarah Johnson, a nurse at St. Patrick, and she conducted this study with Caroline Deasy on decreasing linen use. Sarah.
Hello, everyone. I'm so happy to be here presenting the work that my colleague Caroline Deasy and I conducted at Providence St. Patrick's Hospital in Missoula, Montana, with the support of our wonderful hospital leadership. This idea started out as a unit-based council project when I was a full-time floor nurse. We developed this idea that we could reduce linen use. Oh, I'm not seeing my poster there. Next slide, thanks. Thank you. So we developed this idea that we could reduce linen use on our unit by having patients opt into an every other day linen change that would be good for the hospital and good for the planet. This project almost stopped there. It was tabled due to a lack of supporting evidence. But I never really stopped asking why and was motivated to create the foundational research to justify a change in nursing practice. So in the fall of 2018, Caroline and I took a deep dive into all things linen. We looked at how other hospitals ran successful linen reduction campaigns. We compared linen utilization policies within Providence and nationally. We looked at guidelines published by the CDC and World Health Organization on hospital-acquired infections and hospital linens. We studied financial budgets for linen and ultimately the environmental impacts of linen. So we pulled all of these pieces together to develop a linen utilization policy. We hypothesized that the implementation of our linen policy would not only drive down our hospital's greenhouse gas emissions, but provide financial savings for our hospital, while also giving nurses more authority over their use of linen. So after obtaining IRB approval, we began our study. So we acknowledge that linen is used in so many different departments throughout a healthcare facility, really everywhere. But for the ease of comparison, we focused on 4 inpatient acute care medical surgical units. We instituted our linen policy on 2 intervention units and monitored, tracked, and compared 5 metrics against 2 control units. These metrics, which include the pounds of linen used per adjusted patient day, the amount of clean, unused, excess linen in patient rooms, the rates of hospital-acquired infections, specifically C. difficile, and Press Ganey's patient satisfaction cleanliness of room responses, were analyzed and reported using descriptive statistics, including the frequencies and mean scores. We sent out a linen survey to staff on all 4 units, and their responses pre and post intervention were analyzed using descriptive statistics, including frequencies and means, and an independent samples t-test to determine statistical differences between the pre and post response groups. So on to the really good stuff. What did we find? An analysis of our staff survey showed that there was a change in staff knowledge and understanding of linen use and management, and that nursing staff had increased their awareness and consideration of the energy impacts of linen usage. We were so pleased to find that there was no increased rates in C. diff during the study, since this lack of foundational research was the main sticking point to getting this study off the ground. Next slide. So this figure compares the pounds of linen used per adjusted patient day on the control units versus the intervention units from January to March, which includes the pre-intervention period, and from April to June, which is the intervention period plus 1 month. So as you can see, there was a mild decrease on the control units of about 1.1 pound. We feel that that was maybe due to increased awareness due to our staff survey, and we had also asked staff to track the extra unused linens on their units, so that decrease might have been because of those 2 things. However, the linen decrease on the policy implementation units was much more significant, with an average of 6.5 pounds per adjusted patient day. So after doing a little rough math using our 2019 statistics, I was able to put this into perspective for potential hospital savings. If all of our inpatient units decreased their linen usage by 6.5 pounds per adjusted patient day, this would result in a potential savings of 285,000 pounds of linen, which saves roughly $97,000 in direct linen costs. Now, if we were to extrapolate this to the entire hospital, we would be able to decrease linen by closer to 650,000 pounds, and the cost savings would be closer to $223,000. So this was just an off-the-cuff math problem and not a true life cycle analysis, and it's our thoughts that there would likely be additional savings that are not captured, such as staff time, water, chemicals, and energy use. Next slide. So during the 8-week intervention period, 1,134 pieces of unused clean or excess linen were found in the patient room surveyed using a linen surveillance tool that we created. Looking just at warm bath blankets, which are the heaviest and therefore most expensive to launder, there could have been a savings of approximately $1,600 annually, had those blankets just not been brought into the rooms and stored in patient rooms. One of our limitations was that these linen surveillance tools, there was a low number of them completed. So we actually think that the $1,600 is an underrepresentation of the total amount of extra linen that might have been found and the potential dollars that could have been saved. An additional piece of our project, we looked at the patient satisfaction scores for cleanliness of room. And during the implementation period, this increased on the 2 intervention units. And we basically posited that this was because if you don't have a lot of extra linen stacked in patient rooms, the rooms were likely to be rated as more clean. So next slide. Overall, what did we take away from this project? So this project was uniquely positioned as it looked at the intersection of cost savings, resource conservation, sustainability, patient safety, and nursing practice. Ultimately, we were successful in decreasing linen usage without negatively impacting patient safety or satisfaction. Of course, I think that this project could be expanded throughout the whole system and that Providence has the potential to make a large impact by changing the way that they educate about and manage linens. But beyond that, this project showed how a small change in action at the bedside can have ripple effects throughout an organization. It showed how a change in perspective, a change in nursing culture could positively impact not only the financial health of our organization, but could positively impact planetary health. Early in this research, I dubbed this project my sexy linen study as a bit of an inside joke, given the unexciting nature of linen. But the point sticks. Linen management isn't very sexy, and when it comes to out-of-the-box thinking about environmental stewardship, nursing practice, and hospital management, the actions that will make the biggest impact are likely to look small and unexciting at first glance. Florence Nightingale was an inspiration to me as a young girl. She lived a life of inquiry, and during our Year of the Nurse, and now extended Year of the Nurse, which is really exciting, I invite all of you to do the same. Our solutions don't have to be radical, and it's important to remember that they can come from any voice within our institution who is willing to ask why and question the status quo. Thank you.
Nice job, Sarah. Thank you so much. Beautiful distillation of what was really rather a complex study. So I hope all of you, I'm just going to talk just a little bit here in our wrap up, and you can go ahead to the next slide. I hope all of you can appreciate this breadth of what we've just heard. And this is a tiny sample of the posters that we reviewed, and that's a tiny sample of what's actually happening around our health system. So this whole notion of why the spirit of inquiry is important, I hope is clear to everyone, not only for the reasons I mentioned earlier, but also because we are obligated to do this. This is in our foundational documents, our code of ethics and our scope and standard of practice. Nursing is based on evidence. We can't measure everything, and not everything that we do is amenable to the scientific method, but there's some way to analyze it for its effectiveness, its impact, and its import. Two quick concepts I'd just like to share in our moment here. One is, right now in today's world, we have just had a renewed calling to science and to evidence. This is with COVID and with a lot of misinformation or confusing information that's out there. This has become a problem in our country and perhaps in the world. And I have wondered, do we know as Americans and as humans and certainly as nurses, how to think through conflicting evidence? How do we make a good determination? This is about critical thinking. It's about inquiry, and it's about knowing something about being able to wade through complexity. I think this is something that, we as nurses are already pretty good at because we have been dealing with science for most of our careers. We work with complex situations, but this is another way that we can really help our world and not only our nursing practice. So it's really to fight disinformation by using a rational approach, including the things that we can't measure directly, to at least be having a critical mind about how we interpret what's around us. The other notion that I'll just take a moment to elaborate on, and thank you, Michelle, James, for the mention, is to amplify this work that Sarah just did and how it's related to my work right now, which is about environmental stewardship. I would say, just like we're called again to science right now, we're also called to really care for our common home. We, especially in Providence, a lot of us have just been living through weeks of smoke, and we know that is heightened and worsened by climate change. I hope you all have heard that Providence has made the bold commitment to become carbon negative by 2030. Also, nursing is a large part of Providence. I think Debbie might have to correct me, but around 40,000 nurses, and I think that makes us about 35% of all of Providence. So we have a lot to say about our carbon footprint and our environmental impact. So Sarah's study is an example that we can measure those things. We can analyze our practice and determine, well, what is the best, not only for patient outcomes, nurse satisfaction, and cost savings, but also for our environmental harm. So thank you for letting me just throw that word in. And next slide, please. So the next event coming up is October 28th. You can see it here. And this will be exciting news because we have several new organizations that have been recently designated or redesignated for magnet and pathways. And we'll also learn more about our PTAP programs, which is the educational support work. And that is available on that link there at the bottom. And we hope that all of you can join us, and also for the remaining two after that, November and December. So I would also like to just say personally that since this is sort of one of my last engagements with nursing research in a large way, I am so proud of nursing research in Providence. I am so proud of you all who just presented. I am proud of the Nursing Research Council, who has done so much to try and build and advance this knowledge and work and sharing. I'm proud of nursing generally, and I'm proud of Providence Nursing. So I hope that all of you can enjoy this and celebrate with these fine scholars and think about how you may ask questions that change practice and change our world. Thank you so much.